Thanks, Joan. Okay, so we're going to be focusing on bone health and cancer tonight. The first thing I want to do is just lay out the fact that when we talk about estimated new cases of cancer, it is the case that more men than women are getting cancer. It's not that different, but the points that for bone health, the two cancers that I'm really going to focus on tonight is prostate cancer and breast cancer. That said, I'll at least mention colorectal cancer. The bone issues for lung and bronchus cancer really haven't been explored as much, and I'll just basically move on from that and start out with, when we talk about prostate cancer, I'm not going through all these risk factors. I want to highlight the really important focus. Obviously, this is a male cancer, but the second major risk factor after being a male is age. It's something that really starts to just take off after age 50. And the reason why I want to point that out is that osteoporosis is very much a disease of aging. So this is the first point. I won't go into all the other details. I want to say the exact same thing for breast cancer. Obviously, women predominantly get breast cancer. About 1% of breast cancers are men. But the next leading cause of, or risk factor, is age. Now, I will also point out there's a lot of issues with menopause, or with so-called female hormones. I say so-called because estrogen is very much a man's hormone as much as it is a woman's hormone. We just have more of it. And this is really important with bone health. It's estrogen that's the key hormone for bone health. And we'll talk about that. But there's a lot of issues with breast cancer that relate to your reproductive function. And to just kind of move to this point, when we talk about the reproductive function, if you actually look at breast cancer rates, they really skyrocket, even though they're much lower in young women, premenopausal women, than postmenopausal women. You can just see this really steep curve. You then go through menopause and you reduce your risk of breast cancer. That's really different from heart disease, where people often say women are protected until menopause. There's no evidence of that at all. It's just very much an age issue. But because of this particular point, you can see that if you started your reproductive cycle sooner and started having more estrogen on board sooner, so early menarche, if you have a later menopause, then you're going to keep that steep curve before you flatten off. So these are some of the issues that we talk about with breast cancer. Now, the next one I want to just quickly mention is colorectal cancer, the third most common cancer in men and women. And again, age is now the #1 risk factor. Almost 90% of colorectal cancers are after age 50. So the bottom line is the majority of cancers are in people who are 65 and over. And that's really the time that we're talking about osteoporosis. So I'm going to be saying a lot of things about osteoporosis that relates to everybody in this room, whether you're a cancer survivor or not. Now, when we talk about bone, I'm going to make a few points. One point is we start really putting on a lot of bone mass at puberty. And there's a big difference, sex difference, in terms of girls start puberty sooner, they finish sooner, they actually end up being shorter, they have lower bone density just because of the way puberty works out compared to men. But the key thing is peaking. Where you peak is going to play a huge role into what's going to happen to you with age, and this is just healthy aging. Healthy aging for women includes a big acceleration of bone loss at menopause and then a continuing reduction. But you can basically recognize that at some point you're going to hit a low enough bone density that you're going to hit a fracture threshold. And depending on how you peak, that's going to be a huge factor in where you're going to hit that fracture threshold. If you get cancer along the way, there's a lot of cancer treatments that are going to basically put you into a much faster decline. And in fact, when we look at this, bone loss caused by cancer treatment is really one of the most important new pressing concerns, where there's a lot of recognition that this is a huge issue. So that if I were to talk about bone mineral density, which is how dense your bones are, and coming back to this point, this is bone mineral density, you can basically see that at some point it's going to be so low that you're going to start fracturing. If I was looking at normal men, this is looking at the lumbar spine, so one of the vertebrae in your lower back, The bone mineral density lost at 1 year, so if I was looking year by year, about 0.5% loss for normal men, about 1% loss for late menopausal women, so that's after you've made it through menopause and then you're just going through the slow decline, more precipitous in early menopause. And then look at this set of bone mineral density loss caused by cancer treatment. So I'll start with aromatase inhibitor therapy, now the most common one in women with estrogen receptor positive breast cancer, 2.6%, so worse than going through menopause. Bone marrow transplant, 3.3%. Androgen deprivation therapy, which is the most common therapy for prostate cancer, worse than women going through menopause. Aromatase inhibitor plus gonadotropin releasing hormone, this is basically changing the way the hypothalamus is trying to speak to the gonads or to your testes in the case of men, ovary in case of women, 7% loss. And then ovarian failure that occurs with chemotherapy. And this is generally, this is something that's really common in breast cancer and some other chemotherapy. So the important point is that we're very clear that these treatments for cancer are very bad for your bones. Now when we talk about male osteoporosis, the bottom line is it's not been studied very well. And I'm going to tell you about a study that we're doing that's looking at this. But a point I've already made is estrogen is actually the key to bone in men and women. It's a very much, men really have to have estrogen for most of their functions. We don't have to have testosterone. We can have, if the receptor for testosterone doesn't work, there's actually a syndrome like that, you can be an absolutely normal person, but if your estrogen receptor doesn't work, you don't survive. And so basically estrogen is not just a woman's hormone, but it's not testosterone. And this is through aromatization, which basically means that all the testosterone, to get estrogen, you have to first have testosterone. And then you have a special enzyme in your various tissues that convert that testosterone to estrogen. So that's true of all the women in the room. You're basically able to convert testosterone to get to estrogen. 10% of men 65 and over, regardless of cancer, so this is healthy men without cancer, have osteoporosis. Another 25% have osteopenia. We hardly ever think of it as a man's disease, but that's a big percent. Androgen deprivation therapy, which is commonly used in prostate cancer, accelerates bone loss to as high as 10% per the first year. And that continues at this accelerated rate. So it's actually worse than going through menopause, where we always talk about that acceleration. And the worst thing is that the loss of bone with the initiation of this therapy is not reversed. You can't get that back. And the loss continues even after you stop taking the therapy until the testosterone returns to normal levels. So it's not something to be underappreciated, the importance of bone health for men. Now I will just quickly tell you, oops, looks like my colors didn't work on this computer, but this is not about cancer. The study of osteoporotic fractures in men is a huge study of older men. Francis actually is now 102. And I guess, yeah, he's still 102, and he's still alive. But this was a study where the men had to be 65 and over to get into the study. We have 1,000 of them. We had 1,000 of them. We've been studying them for 10 years, so there's no longer 1,000 left. But it's actually being conducted at 5 other sites. So we have 6 sites in the United States that originally had 6,000 men aged 65 and over, studying the issues for osteoporosis in men, because we really don't have good data on this. And so this is going to be important. Again, it's not a cancer study per se, but these are normal men. Prostate cancer is happening in our cohort. We're following what the prostate cancer role is. Now, coming back to bone loss in men, this is a significant comorbidity, which means disease that accompanies prostate cancer. And androgen deprivation in particular. It's basically one of the most numerous side effects of getting that androgen deprivation. And when we actually look at skeletal fractures, they're an inverse predictor of survival of men who have advanced prostate cancer. So if we look at men with history of skeletal fracture, their survival is substantially shorter than men who don't have that history of skeletal fracture. So it's a really important part of cancer therapy. Similarly for women, if we talk about fracture risk among breast cancer survivors, this study actually came from the Women's Health Initiative. We have a huge observational study. It's a nationwide study. There were 80,848 women who did not have breast cancer, and then 5,298 who did, who were cancer survivors. They were followed for 5 years, and what you can see is there actually really wasn't any difference at hip fracture, which is the most serious fracture, so that's good news. But there were substantially more clinical vertebral fractures in the breast cancer survivors, substantially more lower arm and wrist fractures. We call it Colles fractures. All other fractures, and when we look at the total fractures, there are many more fractures in breast cancer survivors than there are in their non-cancer controls. This might be a little bit hard to read, but I'll just walk you through it. This is basically the line of identity. If everything fell on the line of one, it wouldn't make a difference if you were or you weren't a cancer survivor. And it's basically showing you that for hip fracture, it's the same basic information I just told you. For hip fracture, there really isn't a difference if a woman, this is comparing a woman with breast cancer versus a woman who doesn't have it. But you can see that for these clinical vertebral fractures, we're talking 30 to 50% more fractures of the vertebrae. We're talking a similar 36 to 44%. These are adjusted for different variables, so I can say you can take into account everything and you get these smaller numbers. But this is way over here in the line of significance, showing you that we're talking about 20 to 50% more fractures in breast cancer survivors than non-survivors. Now, over here I've put you some information, and probably many of you don't know how to read hazard ratios and confidence intervals, but I'll just walk you through it and say that there's a big difference between a woman who's younger than 55 and 55 and over. In particular, when we talk about the hip fracture, doesn't matter by age, but the clinical vertebral fractures, 78% more of these fractures in young women who have breast cancer than young women, their age-matched partners who don't. Not true in older women. So younger women in particular are getting these fractures because we don't expect them to have gone through menopause, which a lot of these treatments essentially throw you into early menopause. So compared to your younger controls, they have more of these clinical fractures, clinical vertebral fractures, more of the arm and wrist, and more of these total fractures. So they're worse off, and that's largely because they're going through a much earlier menopause. So what is osteoporosis? It's not just low bone density. It's a skeletal disorder that's characterized by compromised bone strength. So it relates to the architecture of the bone as well. So this is basically predisposing a person to risk of fracture. And the bone strength is not just bone density, but bone quality. And to just give you an example, this is a nice, healthy bone. And any of you who build bridges or who are architects or engineers of any sort can see there's all kinds of cross-stabilizing factors here. This bone is not going to break very easily. You can fall out of a tree or off a roof, which is pretty much how our older men get their fractures. The women pretty much fall off a curb, but the men are like doing their Christmas tree lights or they're doing something up on the roof. So we do have to deal with risk-taking behavior in older men in particular. But here we have osteoporosis. You can see low bone density instead of nice thick bone, really thin. And look at all of, there's like just nothing there giving this nice scaffolding. There's a fracture, there's a fracture. This is an osteoporotic bone. And this is our typical concept of osteoporosis. We usually think of women. You really could put men in these pictures just as easily. You just have to move them about 10 years out. So we would start at age 60 instead of age 50. That's the big sex difference, is the age. So an early menopausal woman still has a reasonably good bone. By the time she's 55, she's already a little bit shorter. She gets a little bit shorter. The shortness is because she's getting breaks in her vertebrae. It's just like those cups we used to put in our purses that collapse down. Your vertebrae is just slowly collapsing down as you get these fractures, and so you become shorter because you just don't have these nice thick vertebrae. To the point where we get into the 75-year-old kyphotic woman who's at now very high risk for hip fracture, very high risk for vertebral fractures. And here's a healthy spine, and here's this kyphotic osteoporotic spine. Now there's a whole bunch of things you could have done if I talked to you when you were still children, but it's probably too late for that now. We'll talk about this other end, but one thing is there are some nutritional issues that will help you get that peak bone density. And this is a big problem we have now with children because they're not drinking milk, they're drinking sodas. But you need to get enough calcium to get to the peak bone density, and that's going to make a big difference once we start talking about this. Obviously, it's always great to have good genes. Hopefully you picked good parents. Exercise is a really important part of this, and then there are some structural errors, but all of this goes into this problem. Now, when we talk about risk factors for osteoporosis, most of these have really been worked out in women, and that's why we're doing the Mr. Oss study. We recognize that men are living longer. For women, we start worrying about osteoporosis at age 65 in a big way, unless they have a lot of risk factors. For men, 75. So it's a 75-year difference. But men are living long enough that now we're seeing more and more of these fractures. And you should just know 1 out of every 3 hip fractures is a man. So it is not a woman's disease. It basically is getting plenty of men. But age is the number one. And then most of these, as I say, relate to women. So going into menopause earlier, which cancer therapies put you into menopause much earlier. You get ovarian failure with some of these treatments. So primary or secondary amenorrhea, which is basically your menstrual cycle stopped, the ovaries no longer producing enough estrogen. Family history, low body weight, so the really thin person is more at risk for osteoporosis. Smoking, these two are actually quite tightly related in some cases. Excess alcohol intake, not as much for the bone integrity as the fact that a big problem with fractures is falling. And if you drink too much alcohol, you're going to have some problems. Similarly with prolonged immobilization, you have to be on your feet, you have to be moving, you have to be up and about to keep the bone integrity. They've seen that bed rest is one of the worst things you could do for your bone. Well, the worst thing would be going out in outer space and flying to the moon, but probably most of you won't get that chance. But bed rest, people have done studies where they show that if you just get out of the bed and stand for 5 minutes, you can maintain your bone better than if you're just lying flat. So mobilization is something that we really do work on that one in hospitals. The poor visual acuity is the same thing as the alcohol. It really relates to falling. We're going to talk about fall prevention. Certain neuromuscular disorders, primary and secondary hypogonadism in men, and this is one of the things that these cancer therapies basically bring about, secondary hypogonadism. Your testes basically are turned off in prostate cancer in terms of really reducing the testosterone, and this is a big risk factor. Other ones I'll just point out is chemotherapy, the anti-estrogen and anti-androgen treatments, glucocorticoid therapy, which is part of some of the cancer therapy. And I'll talk about bone turnover as we move on, and obviously if you've already had a fracture, it's a signal that you've got some problems. Now, not talking about breast cancer per se, but just to understand that in a woman, when we talk about the age issue, whether you have breast cancer or not, at about age 65, we start to see this huge increase in vertebral fractures. For hip fractures, there's an inflection there as well. It really starts to pick up after age 70, and here are these Colles fractures. So age is a huge issue, whether you have breast cancer or not. And this is also showing you that if you actually have one of these fractures, the risk of death is very, very high in a short period of time. This came from the let's see, I don't want to call it the mother study, but the study of osteoporotic fractures of men is really the male counterpart to the study of osteoporotic fractures, SOF, which is of women. But that study was done 15 years before Mr. Oss was done. So it took us a while to get the Mr. Oss study going. But the point I want to make here is that your risk for actually dying after you've had a hip fracture compared to a woman who didn't have a hip fracture is 6.7 times greater. For spine, 8.6 times greater. So basically, these fractures are really highly predictive of not doing very well. Now, I want to give you a little bone physiology. So with this schematic, basically bone loss is an unbalanced bone remodeling system. What we have with bone is, you should know that your bone is very much alive. It's not just a static skeleton. Every single day you are resorbing some bone and building in new bone. As you get older and older, it becomes harder and harder to put that bone back in place. But we have two basic kinds of cells. We have osteoclasts that have the job of basically, they acidify and proteolytically digest, so they go into bone and they chew it up and they basically resorb the old bone. You're replacing bone with healthy living bone. They get rid of that old bone. And then the osteoblasts come in, and it's their job to go in there and put down a collagen matrix and lay out new bone so that you end up replacing old bone with new bone. And then once that osteoid becomes mineralized, you end up filling in that hole. Now what happens with osteoporosis is you become less and less good at filling in that hole, and you end up with more and more of these gaps. And so this is a case where you're already seeing a problem. Now the reason I wanted to bring this up is that when we talk about drugs for bone, we talk about anti-resorptive drugs. These are drugs that are trying to prevent the resorption. So the way they work is they prevent this action so that you're not chewing up your old bone. Most of the treatments for bone are anti-resorptive, and there's really only one that is totally for just putting in the new bone, and we'll talk about that. This is another schematic just to kind of lay out the fact that if I looked at a bone, some of this stuff that I'm talking about is happening inside the bone marrow. So we actually, as we're developing bone, as children in particular, we're chewing out old bones so that we can get bigger and bigger bones. Otherwise, we'd have these little teeny children bones. So we have to like chew it out and just keep making the tube bigger. But most of what we're talking about is on the surface of the bone and trying to keep the surface of that bone intact. Any questions? Okay.
Are the osteoclasts and osteoblasts working at the same time at the same space, or are they sort of separated?
They're kind of working together. They interact with each other.
Being dug and filled in at the same
Yeah, so he's asking, are they working separate? They're generally working in concert so that one is digging out the hole and the other is filling in the hole. Now, I put this picture back just to remind you, when we talk about the anti-resorptive agents, the one that most of you will have heard of is bisphosphonates. This is how bisphosphonates work, is they're preventing this hole from being dug out. The really common ones, alendronate has been around a long time, residronate, abandronate, which is Boniva. You can have this as oral or IV. Cylindronic acid is reclassed. It's usually IV. And then we have other anti-resorptive agents, which is estrogen, agonists and antagonists. I'm going to talk to you about raloxifene, which is a Vista, which is what we call a SERM, selective estrogen receptor modulator, and I'll explain what that means in a moment. But these are also FDA approved for osteoporosis. There are estrogen and estrogen progestin combinations that are approved, calcitonin, miacalcin, and Forticol. And then the only one that really is working on putting the bone in is anabolic therapies, and that's Forteo or teriparatide, which is really working on parathyroid hormone. So I want to talk about SERMs first, and obviously this is women. The ideal selective estrogen modulator. Estrogen is everywhere. I study estrogen. I love estrogen. It's in your brain, it's in your bones, it's in your heart, it's in your skin, it's all over the place. But when we talk about estrogen, it has good effects and bad effects. And this is what we've studied in the Women's Health Initiative, was that balance. When we talk about an estrogen for breast cancer, of the large percent, the majority of breast cancers are estrogen receptor positive, meaning that if you get estrogen in that breast, it basically will stimulate receptors in the tumors and you end up increasing your breast cancers. And I think it's about 75% of breast cancers are estrogen receptor positive. So we don't want estrogen if you have breast cancer. We want to block that estrogen. And so when we talk about the SERMs, he's getting his, The SERMs are trying to reduce breast cancer risk by going into the estrogen receptor. So just something to understand is the way hormones work is there's a receptor in your tissue that the hormone's going to come in and bind to it, and when that binds, it then goes into the nucleus and turns on whole machinery so that you end up with whatever the product will be. So that could be hair, it can be whatever the product will be. What you want to do with breast cancer treatment is you want to block that. You want to put something in that receptor so that it won't do anything, and we call that an antagonism. If you wanted to do that through your whole body, you would want to do that also for uterine cancer. You'd want to block estrogen from being able to stimulate your uterus, but you sure don't want it to not be working on your bones. You don't want to get osteoporosis. And so there's been a lot of work, and it also affects LDL cholesterol, HDL cholesterol. For some people, it deals with hot flushes. What we've been working, what the scientific community has been trying to find is the perfect silver bullet that will only stimulate the estrogen things you want and block everything else. And we don't have anything like it, but we do have a couple. So to just kind of, this is a lot of information, but just to see what kind of research has gone on. How many of you have heard of tamoxifen? Okay, tamoxifen used to be the treatment of choice for a woman with estrogen receptor positive breast cancer. Tamoxifen basically was tested in a huge primary prevention trial called the BCPT of women who were at high risk for breast cancer but did not yet have breast cancer. And it was a randomized study of getting tamoxifen versus placebo, and the hope was that they could prevent you from ever getting estrogen receptor positive breast cancers. And in fact, it was very successful. 49% reduction in the women who got lower cases of invasive and non-invasive breast cancer if that tamoxifen was there instead of placebo. And it was 69% specifically for these estrogen receptor positive tumors. The problem was it increased endometrial cancer, it increased stroke, which we know estrogen does, it increased pulmonary emboli, which are blood clots in your lung, deep vein thromboses, which are blood clots in your leg. This was mostly in women who were 50 years and over at higher risk. It actually increased cataracts. And in terms of bone, it really didn't have significant benefits to bone. There were decreases in hip, spine, wrist, and fractures. They weren't quite significant, but you can see part of that might just be the size of the study. If they had a larger study, I think we would have been able to demonstrate that tamoxifen was a partially good SERM in that it had the breast cancer prevention part. It seemed to be helping with bones and preventing fractures, but it had all those other problems. So people wanted to find something else. Well, the meantime, the osteoporosis people were off looking at their own SERMs. They wanted to find something other than estrogen that wouldn't cause the blood clots and the stroke and all these other problems, but would help the bone. And this was raloxifene. So how many of you have ever heard of raloxifene or Avista? Okay, not as many as tamoxifen. So basically, this was being studied for osteoporosis, not for breast cancer. These women had osteoporosis. They were much older than the previous study. It was a little bit shorter study, but they were randomly assigned to raloxifene or placebo, and they did see increased bone density in the spine and the femoral neck, which is basically the top of your femur, and they got reduced vertebral fractures. They didn't actually get reduced hip fractures, and as a surprise to some extent, they saw less breast cancer. It wasn't a very big study, and it actually was the case that you'd have to treat 126 women to prevent one breast cancer, so you'd want to be sure it was a good drug. It didn't cause this endometrial hyperplasia, so you didn't get the problem in the uterus that tamoxifen had. It did cause more blood clots, and it had some other unpleasant side effects. But this was basically something that the NCI, the National Cancer Institute, felt like we should do a head-to-head. This seems to be better than tamoxifen. Let's do a head-to-head. And it was called STAR. And just out of curiosity, how many of you were in the STAR trial? Nobody, okay. Because Stanford was one of the sites. But this was basically putting tamoxifen versus raloxifene, already believing that tamoxifen would prevent breast cancer, so we just wanted them to be equal if anything. So this was a large study. The women had to be 35 and they had to be at increased risk for breast cancer but not yet have breast cancer. 6 years, so a bit longer, tamoxifen versus raloxifene, no control group. We were just going head to head with these two. And basically, they were able to show that raloxifene was just as good as tamoxifen for preventing breast cancer in these women. But they had fewer cases of non-invasive breast cancer, so tamoxifen kind of, this is an unknown reason why tamoxifen does that, but it's not that big of a deal. They didn't see any differences in endometrial cancer, however, so it wasn't any better. And they didn't see any differences in stroke and ischemic disease, so it wasn't any better. They had fewer blood clots, so that was a bit better. They had fewer cataracts, so that was a bit better. And there was absolutely no difference in what was going on with the bones. So raloxifene kind of won, and that's one reason why more and more physicians are going to raloxifene, and you don't hear about tamoxifen so much. That said, this whole issue is trying to prevent estrogen from getting into the receptor and doing something. So this would basically be estrogen would get to that receptor and cause the cell growth. And so the SERMs, tamoxifen, raloxifene, were really aimed at preventing that estrogen from binding. In the meantime, another whole approach came along called aromatase inhibitors. And aromatase is basically what I told you in the beginning. We first make an androgen or a testosterone, and then we convert it to estrogen. So the way to really reduce estrogen in your body is to prevent the testosterone from being converted. And this is basically what happens is you don't end up with estrogen, and you start to become really estrogen, low estrogen levels, and that will reduce your breast cancer. But what do you think it does for your bone? So this is the dilemma. We can't get the perfect thing. So this is basically aromatase inhibitors prevent these androgens from being converted to estrogen, so you don't stimulate the breast, but then you have the problem that you're not stimulating the bone either. This is probably kind of hard to read, and I didn't realize that until I saw where you were sitting, but I'm going to walk you through it. So this is a patient with breast cancer who's initiating or receiving aromatase inhibitor therapy, which is now generally used instead of tamoxifen. So those of you who were on tamoxifen probably know that you're supposed to take vacations from it, you stop it for 5 years. A lot of people now go to aromatase inhibitors. When we talk about T-scores, these are based on, this is basically related to bone mineral density. When you do a DEXA test, a dual emission X-ray absorptiometer, they basically look at what is your mean bone density and how far does it deviate from a young woman. So basically the T-score is, it's kind of confusing, but it's the standard deviation compared to a young woman. For men, we actually do have male-specific guidelines, and we compare you to young men in your T-scores. But the T-scores are really kind of statistically derived standard deviations. And if you, usually the definition of osteoporosis is that you are a minus 2.5 T-score, which means you're lower, you're more than 2.5 standard deviations below the mean for a 20-year-old white woman. And by the way, we don't have good ethnic data, it's white women. But at any rate, to kind of talk about this particular scenario, if a woman is getting these aromatase inhibitors, we would look at her T-score to decide what's going to happen to her. So if she had a T-score that was above that cut point, in this case for these women they're using 2, and you had no other risk factors, we would just recommend exercise, calcium, vitamin D, and we would basically want you to come back and get your bone density tested again. On the other hand, if you have any 2 of the following, so T-scores that aren't quite as bad as this, but you're 65 and over, and you're thin, and you have family history of hip fractures, and maybe you have a personal history of fragility fracture after the age 50, or you're on oral corticosteroid use for more than 6 months, or you're a smoker, any of those things, or just this T-score, will throw you into still exercise, but bisphosphonate therapy. And that's pretty much what happens now. Women are put on bone therapy simultaneously with these aromatase inhibitors because we can't afford to lose that much bone. And then you monitor the BMD. Now this talks a little bit about, there's a lot of data, information here. I should have typed it all in, but I just cut and pasted it. That basically it's telling you that if you lose more than 10% of your bone mineral density using the same DEXA machine in a year period, you need to look and be sure there's not something else going on, like maybe you have vitamin D deficiency. And that would be the kind of thing that you'd have to really follow that, because that's way too much bone loss in a short period of time. I'll talk about osteonecrotic jaw in a moment. Now, when we talk about the mechanism of action, the bisphosphonates, they actually work at 3 different levels. They work at the tissue level by reducing bone turnover. So bone turnover is this issue of you're chewing it up and you're putting it back. And so we have markers to tell us how well is that turnover happening. Are we really getting rid of the old bone, putting down new bone? Cellular level, we can talk about actually inhibiting the osteoclasts, both their activity at the surface of the bone, so remember that picture, and recruiting new osteoclasts onto the bone surface so these cells can actually say, hey, I can't do this job by myself. Come on, I need more cells, and they'll do that. And you actually can chew up these osteoclasts. And then at a molecular level, I'm not going to go into that. I'll just tell you that it's a very dynamic process, bone. You are basically remodeling your bone every day, and hopefully you're putting it all back down and not just losing it. When we talk about these treatments, these anti-resorptive therapy, it does produce a modest bone mineral density improvement. It also decreases the biochemical markers of bone turnover, so we're basically seeing that it's slowing down what's happening. It's not going to happen so fast we don't have to run the risk of losing so much. This decrease in the resorption is followed by a decrease in formation, and so then the improvement basically plateaus. But the decreases in fracture risk, especially in the spine, occur a lot faster than these changes in bone mineral density. So we know something else is going on, but we don't know what it is. But this is something where you can't just go by bone mineral density, and that was the first. We used to use bone mineral density as the marker of success of these drugs, and then we realized, wait a minute, this thing is doing something without putting in as much bone mineral density as estrogen might, but with a much better result in terms of reducing fractures. Now, the anabolic therapy that I talked about, which was the only one that's actually causing osteoblasts to do more stuff, does increase bone mineral density a lot more than bisphosphonates do. But we're not really sure that it's protecting you against fractures yet. So this is the challenge, is we're using bone mineral density, but until we really know, does that really result in a stronger, better built bone? We can't just use bone mineral density, which is why the definition of osteoporosis includes bone integrity as well as bone density. So when we talk about bisphosphonates, there's a lot of them. They're coming up with new ones all the time. They come in relative potencies. So you can see that these things are like, by the time we're talking about zoledronic acid or Zometa, this is very intense. And this one actually is one of the ones that people are now injecting for a year because they're so high. And to be honest with you, I tried to think about this today, and it's like, I don't know where it goes. I'm not really sure like where it's hovering for a year. So I'm sorry I don't know the answer to that. It's like you start coming up with the questions, you know, too late to be able to present it to people. But this osteonecrosis of the jaw thing, how many of you have heard of that? Okay, so I want to say something about it. It is associated with use of bisphosphonates. It's very uncommon. It does seem to be, we started to first see it when they were doing radiation therapy to tumors of the head and neck. We know that radiation creates a hard and soft tissue, hypoxia, and there's changes in cells and blood vessels. And the main thing is it results in reduced healing. And so if you get exposed to bacterial infection, then that's where you start to get into this problem of the jaw. And all I'm going to tell you is that this is just a real important, dental hygiene is the key. Try and prevent those bacterial infections from occurring. But it's really very uncommon. Everyone got all excited about it, but it's very rare and it's not a big deal. But the more important thing is the dental hygiene. Now, when we talk about this, the zoledronic acid or Zometa, these are common things that happen. You're going to inject this once a year. Did I fall something? You're going to inject this once a year, and what you see is that people will have certain kinds of symptoms. So pyrexia, where I think this is a burning sensation. Myalgia, where you've got muscles that are really painful. Flu-like illness, headache, and arthralgia, which are joint problems. And so you can see day 1, 2, 3, a lot of people will have these symptoms, then they go away, and you can wait until next year for that problem. But it is something just to be aware that you're not going to get something this powerful just injected and get away with it completely. Now, these graphs are a little bit complicated, but again, I'm going to walk you through them. I'm going to show you 2 studies that provide what I think is the kind of clinical trial evidence that we want that this works for cancer survivors. So this is a randomized double-blind placebo-controlled trial. That's considered the highest standard. It's not huge, so it kind of falls down on that regard. 87 postmenopausal women post-chemotherapy for breast cancer. And this is residronate. So this is common bisphosphonate. And what you see in this graph is these are different sites of bone, different bone sites. So I'll just pick the total hip, but I could take, some other part of the bone. We'll take the total hip. This is the placebo. Over a year period of time, a woman who gets chemotherapy for breast cancer will be losing bone mineral density at the hip, unless she takes residronate. And here you see that you more than retain, you increase your bone mineral density, and then you get to kind of stay there. And it's true at all these other bone sites where we see that chemotherapy clearly results in bone loss, and residronate increases the bone mineral density. Now, these are just turnover markers showing you that you want to decrease the turnover, which the residronate does. And if you didn't have the residronate, you would increase or stay the same. So that's changing the dynamics primarily through the anti-resorptive action of residronate. Very similar study in men with prostate cancer. So this is a randomized double-blind placebo-controlled trial of oral alendronate in 112 men with non-metastatic prostate cancer who were also getting this androgen deprivation therapy, which is very common therapy with prostate cancer. And again, very much like the other bisphosphonate, you see that the placebos in all of these different bone sites that are being measured, so again, I'll take the hip, that if you get if you get the ADT without the bisphosphonate, you lose bone, lose bone, lose bone, lose bone. If you get the therapy, you can increase your bone density, and basically this alendronate, this is now a weekly thing, prevented bone loss, and I could say the same thing with the turnover. So we have really good clinical evidence that it does retain, that these treatments are appropriate for cancer patients. So to say a few more things about men with advanced prostate cancer are at increased risk for skeletal problems. Part of it is because they're older. The older you get, and cancer is a risk factor, age is a risk factor. They actually start to get lower testosterone because with advanced disease. It could be low levels of vitamins that are associated with these cancers. We now know that we are treating these cancers with more prolonged androgen deprivation. And so basically this is an issue. And I will point out that although these are not FDA approved for that indication yet, we are using them. So this is for the indication. It's not specific for this indication, but the bisphosphonates really are what is being used now. So men should, if they're getting these prostate treatments, this androgen deprivation therapy, they should at least know that we've got at least 2 drugs now for which we have reasonable data that they will help you preserve your bone. A point I want to make is for those of you who have prostate cancer or who know someone with prostate cancer, most men are receiving androgen deprivation therapy, or many men are. If you are, you really should get your bones checked. And basically you should be monitored. Just getting a DEXA is good enough. There is recommendation for calcium, vitamin D, exercise, and lifestyle for everybody. I'm going to say some more about that as we go on. There's a subset of men that really do need more treatment. This is something, I'm not a physician, so I'm not going to answer medical questions about what you should do. You really should go to your doctor. But at any rate, you need to be monitoring this. Now, what I'm going to do now is, when we talk about the bare bones of surviving cancer, basically preventing osteoporosis, preventing fractures is true whether you have cancer or not. So these messages now go to everybody, regardless of anything. So this is actually a really cute little slide that is showing you the active bone growth through puberty into adulthood, and then the slow loss, the rapid loss, less rapid, and by age. But the Surgeon General, Surgeon General has a very nice report on osteoporosis, and there are 5 simple steps, but I'm going to give you lots more besides that. One is to be sure that you're getting enough calcium and vitamin D, and I'll show you what that is in a moment. Be physically active. This is true about I never give a talk without telling people they need to be physically active, because there isn't any disease that we know of where that's not a good recommendation that I can think of off the top of my head. Improve strength and balance, we'll talk more about that. Avoid smoking and alcohol. Talk to your doctor. Have a bone density test and take medication when appropriate. So in terms of the bone density test, we don't recommend bone density tests for everybody. We recommend it for people who are 65, women who are 65 and over. For men, we don't actually recommend it yet, which is really, I think, unfortunate. But there's a big recent report that still doesn't recommend it. But for people taking cancer drugs, I recommend it. If you're taking these cancer drugs, they are basically they're really changing your bone dynamics. So the first thing about osteoporosis is just having low bone density is not going to necessarily cause a fracture. It's pretty rare that you're just standing around and suddenly you fracture. You fall. That's usually the case. Now, it's not always the case. You can pick up a bag and fracture a rib. You can do things like that. But the first thing I want to say to everybody is prevent falls. And it seems really obvious, but I bet most of you don't do most of the things I'm going to talk about. So first of all, improve your balance, coordination, and strength through weight-bearing physical activity like dancing, tai chi, but not just walking. That's not good enough. You really have to be focusing on getting weight-bearing physical activity and balance, coordination, and strength. So yoga has lots of nice balancing poses. Review your medications. Have your vision checked. I can't tell you how many older people don't get their glasses changed. And we all know that when you hit 40, you can't read anymore. And when you hit 50, then something else goes out. And it's like each of these milestones. But get your vision checked and make your home safer. So I want to talk about home safety. Okay, so there's a bunch of things here. I don't know if you can read them, but I'll talk you through them. There's actually, this is this woman's home that's been labeled. So number 1, handrails and plenty of light in all the stairways. Don't go down dark stairs. Handrails that work. It's really important. Trust me, I know about people falling. Shoes that give you good support, non-slip soles. I'm not sure my Birkenstocks count, so that's probably not a good idea. Don't use step stools. Get the items in easy reach. Don't be up on step stools where you're going to fall. Get the items so they're easy to reach. Change the way you've got things. So let's see, number 3 is here. It's kind of dark. You can't really see what we're talking about. Here was her, the shoes, and here's that. Okay, maintain a clear path to the bathroom. You're getting up in the middle of the night, especially men with that benign hypertrophied prostate gland. A lot of men get that. Be sure that it's clear so that you can get there. Ideally, have little lights along the way. Remove all small rugs. So there's a rug in this room. Let's see, 6. You can't see it, unfortunately. It's really nice when you can, but at any rate. Get rid of those little rugs. Make sure your walkways are wide enough. Remove things you can trip over. These are so obvious. I want you all to go home today and look at your houses and see if you meet these guidelines. Move the phone and electrical cords from the paths and the open areas. Well-lit rooms, use bright lights. Be aware that some medications, including over-the-counter medicines, can make you dizzy and sleepy, and that's going to make you fall. And get your vision checked. I already said the vision check. And then there's 2 other items. Still in the bathroom, remove small rugs. Use non-slip mats in the bathtub or shower. Have grab bars. You know, you really need a grab bar. More women fall in the bathroom than any other room in the house. One reason is that there turns out to be a chair without arms in the bathroom and nothing to grab onto. So these are important little take-home messages. Prevention, you're never too old, you're never too young to start doing this stuff. So for adults, the bone density test, if you've had a fracture already, you start at age 50. Everyone else with risk factors, and it turns out that if you have a history of cancer or cancer treatments, like radiation or chemotherapy, that's a risk factor. So you want to get your bone mineral density earlier than you would if you weren't a cancer survivor. We've talked about physical activity, at least 30 minutes, moderate physical activity each day. Strength and balancing too, not just walking. You need to do the strength and balancing. Protect from falls, eye exam, extra calcium, vitamin D over the age of 50. We'll talk about that in a minute. Medication, if indicated, to prevent bone loss. So we've talked about the medications for that. Okay, so calcium and vitamin D, the Institute of Medicine reviewed all of the literature and basically came up with slightly revised guidelines in 2009. People were still talking about huge doses, mega doses of vitamin D, but essentially what they came up with is still 1,200 milligrams per day of calcium, but 600 milligrams if you're 50 to 69, and then 800 if you're 70 and over. So it is the case that older people would be getting more vitamin D. Now, you don't just have to have dairy. I just recently have vegans visit me, and you realize, wow, you can't eat anything. But you can. You can eat all of this stuff. So we found all the great things, and we found Califia, which has a vegan menu, and all kinds of things. But at any rate, we have these guidelines. We can give you, you can read labels to see where your calcium is. But you should know that the N-Haynes data, now this is 10 years old, 11 years old now, that from the N-Haynes data, fewer than 5% of women were meeting the guidelines for calcium and vitamin D. And the medium calcium intake from food is less than 700 milligrams. So it's really hard to get it. And that's the issue, is that we have to start to think about, do we want supplements or not? And I am going to show you something from our study that the women were 50 and over, so it's true I didn't have any younger women in that one to talk about that. If we talk about weak bones, these are your issues. The 65 is the cut point. If you've broken a bone after age 50, that's a risk factor. Your close relative has osteoporosis or a broken bone. All women over 65 should have one. Your health is fair to poor, smoking, underweight. So those are key issues. The menopause before age 45. Never gotten enough calcium. That's a hard one because how do you know? 2 drinks of alcohol several times a week is a risk factor. Poor vision, we've talked about falls. I'm not physically active. And I added the cancer treatments because there's 2 more lines that give you this long list of things. And there's a lot of medications and a lot of diseases that you have to take into account. But for this audience, the cancer treatment is the key. I want to tell you one quick thing about calcium and vitamin D. We actually studied this in a huge trial. The Women's Health Initiative had a big diet trial, a big hormone trial, and women who were in that, so this was a trial of 49,000 women that we were looking at cancer, breast cancer, and colon cancer. And the hormone trial was 27,000 women. We were looking mostly at heart disease, but also cancer. And then women in these trials could come into a calcium vitamin D trial. The focus was hip fracture. These were women who were 50 to 79 years of age. We were giving them 1,000 milligrams calcium carbonate and 400 international units of vitamin D. They got half a pill. They got a pill with half of that in the morning and a pill with half of that at night versus placebo. And it actually was the case that it wasn't significant for reducing hip fractures unless we did the analysis with women who were 60 and over. So it really wasn't doing much for women in their 50s who are close to menopause. It really kicked in and did its action at age 60 and over. And then they got a 21% decrease in hip fractures. That said, It didn't reduce colon cancer, which was the expectation for vitamin D. And that was really what kind of set off the idea that, well, maybe 400 international units isn't enough. And that's really, like, now you know, vitamin D, you hear it, everybody hears it. You're all deficient, I'm sure, because everyone I know is getting tested and they're finding out they're deficient. And what we really have to do is figure out, are you deficient? What are the issues? We don't have those data. We just now have this craze, and I've already lived through the hormone craze, and the vitamin E craze, and the beta-carotene craze. So we've all lived through all these things where you're going to die tomorrow if you don't do this, this, and this. And I will say that at least the calcium part did result in kidney stones, so it's not completely benign, and you don't want to overdose calcium. So I think that's an important thing, is you don't want too much of a good thing, because that's not how it works. That said, I do want to point out, for the last cancer to mention in this, the vitamin D story is really important in skin cancer, because everybody is saying, get out of the sun, protect yourself from the sun, you know, be sure you're not in the noon sun, wear sunscreen, wear long sleeves, wear hats, wear lots of, you know, really put on lots of this sunscreen. She's being sprayed here. But this concern is that we may be getting vitamin D deficiency because we are getting really good at keeping out of the sun and lathering up in our P50 factors. And at least my colleague Jean Tang did this study that showed that basal cell carcinoma patients were 3 times more likely to be vitamin deficient, because that group is told, really get out of the sun. So with that regard, note that the body does make its own vitamin D if you're in the sun. There's a lot of foods that are fortified with vitamin D so that you can get those sources. But this is now one of kind of our new dilemma, is how do we not get skin cancer and not get vitamin D deficiency? So this is kind of one of the issues. And I'm just going to end with a slide that I always end with, which is kind of to optimize health across a lifespan. I don't care what your problem is or what your health issue is. Be physically active is first and foremost. We really need to get that message for everybody, cancer patients, heart disease patients. Maintain a healthy weight, vegetables, fruits, and whole grains, restrict saturated fat, limit salt to about a teaspoon a day. That's including what you put in that you've cooked. It's not, you know, just don't put the salt shaker on the table. Limit alcohol to 1 drink per day or less. Minimize stress. Get enough sleep. I never do that. That's the worst one for me. Monitor and manage risk factors. And for women, I can just tell you that we've already answered the menopausal hormone story. It's for hot flushes, it's great for that, and that's really all that we should be thinking about. When we talk about for bones, we do talk about estrogen is good at preventing bone loss. It's not FDA approved to treat osteoporosis. So once you've been diagnosed with osteoporosis, the recommendation is to go to the bisphosphonates or to the raloxifene, and you'd have to be really bad off to get to the anabolic ones. So this is actually, when we talk about vitamin D, we've set these cut points, and so 30, it says nanograms per ml. So 30 is the cut point, 30 and above is considered good, 10 and below is very deficient, 20 to 30 is like border, well, I guess below 20 is deficient, 20 to 30 is borderline. So that's the guidelines that we're using, and you know, all these cut points are kind of, you know, what if you're 29.999? So they're a little bit fuzzy, but those are the cut points. There is an upper limit for vitamin D where they don't recommend that you go above it, but you know, vitamin D is interesting. I don't know enough about exactly how you treat it, and this is where I want to be sure you know I'm not a physician. But when you really are vitamin D deficient, they give you huge doses for short periods of time until you get your blood levels up, and then they cut you back down. So to give any kind of number, you have to take into account how long are you taking that vitamin D. And this is something I don't want to give you a specific number because I don't know what your levels are. I wouldn't want to, you know, get into that. Well, calcium carbonate, you know, is cheap, and so that's why we recommend that. There's a lot of different calcium supplements, and I can't really, I don't, you know, some are really expensive and some are cheap, and so I don't really have a recommendation for which calcium. They all kind of do the job. You know, I've never seen anywhere where they say that if you're taking Fosamax, you should take lower levels of calcium. It's an interesting question, and unfortunately, I won't get to see you again to answer it for you. But it's not something that's blaring. That's you know, that comes out every time you look at a Fosamax article. It might be buried somewhere, but I don't believe that. Pardon?
Yeah, oh, I'm an internist, and you do need it still. It's as important, in fact, to take the calcium and the vitamin D while you're on Fosamax.
Why salt should be limited? Mostly for blood pressure regulation. That, you know, it does increase your blood pressure, so that's the main problem with salt. I think if you've lost height, you've probably had some fractures, or you at least have lost, you know, it's not necessarily that you've had a fracture. You also you have discs between your vertebrae, and they kind of start to lose. So I probably I overstated that. It could be other things that you're kind of losing pressure in the discs. Yeah, it's a combination of things. So actually, this is a hard one to say, but one of the leading causes of death after getting these fractures, blood clotting can be part of it. You can have a blood clot released from the fracture, but it actually turns out that getting pneumonia in the hospital is a really big killer. So going to hospitals turns out to not be a really healthy place to be. So that actually is one of the explanations for this. But these women are very frail when you're getting these fractures, and so there's a lot of issues that relate to the frailty. And so it's kind of a complicated reason, but pneumonia is not to be discarded as a problem. So the answer is you can get too much calcium and it causes kidney stones, but in terms of the microcalcification of the breast, there's no evidence that I know of that that's related to getting too much calcium. What you have to realize is that the tissues in your breasts really have, you know, they have the ability to extract calcium from the blood, and you then end up still having that potential. But usually microcalcifications do show up on mammograms. They don't become cancer. They basically give you a sense of false positives for breast cancer. But microcalcifications are not uncommon in mammograms. But I'm not aware of any direct connection. So I'm going to look at you. If you get the MD, you get to be the authority on all topics. It's possible that it's your bone. Certainly when you bang your knee into something, that's your bone. But probably it's muscle. And it's probably, if you are going faster than you usually go, you probably have muscle. That, you know, muscle's attached to bone, so it could be feeling like it's hurting at the site of the attachment. But most likely, if you're exercising more than you were, I would be willing to suspect that it's your muscle. How does it help your bones? Well, multiple ways. So one thing is, as I said, your muscles are attached to your bones. And, you know, pulling on, the force of pulling on the bone plays a big role in the remodeling. I mean, one of the things, to maintain your bone, you want to have that force on the bone. So that's going to help the bone. We have lots of evidence of that. But the more important thing is that muscles really will help you will prevent you from falling, because you're going to be stronger. Balance exercises, you basically will learn how to balance and not fall. So that's the key, is not falling. But in addition, pulling, the muscles pull on the bone. I mean, they can pull really the wrong way. So tennis elbow, for instance, is when you keep putting too much force and it just keeps pulling on that bone spur. The osteoblasts are kind of overriding the osteoclasts, and you end up with a bone spur. So you can misuse your bone, your muscles, and they'll pull on your bone. But for the most part, you know, having any force on the bone is really important for the health of the bone. The data for exercise, I think, are pretty convincing that doing the exercise, especially weight-bearing exercise, is beneficial to the bone. Whether it's enough, you know, depending on what the forces are that are causing the bone loss, I can't answer that. So that's, you know, a challenging one. In terms of the diet, I think that if you have inadequate calcium and inadequate vitamin D, that's certainly going to set you up for more bone loss. You know, whether you know, in terms of how high do you need to go, I don't think, you know, there's only so much that the bone is going to be pulling in. And the challenge with calcium is that it is somewhat dependent on estrogen to actually result in it moving out of the blood into the bone. So there are problems once you're postmenopausal. If you don't have the estrogen, or if you're not taking estrogen, the calcium, a lot of it you're just losing. You know, estrogen has these amazing effects on the kidney. It prevents you from peeing out calcium. It basically brings it back on board. It has an amazing effect on the gut. It helps you absorb more calcium, and then it has this effect directly in the bone cells. So there's a lot of things, and unfortunately after menopause we have much lower estrogen levels. So it's not an easy answer to your question. Yeah, I must have misspoke then, because it was an increase in it was a decrease in hip fractures, spine fractures, and Colles fractures. It just wasn't significant in that particular study. And I think the problem was when you're talking about that age group of women that were in the tamoxifen study and also the STAR study weren't really at a high osteoporosis age. And so I think that it might be true when we start talking. But tamoxifen is a SERM. You know, it's definitely blocking the estrogen in the breast and helping the bone. But then it has all those other bad estrogen effects. Well, we have, I mean, I showed you the slides that you actually do increase your bone density when you go on to the bisphosphonates. So you actually do increase bone density to a point, and then it levels off, so you're not losing it again. But yeah, we can see that. And estrogen does that too. You actually see an increase in bone density. If you've already started losing, you can basically prevent, you can reverse that and then go up a bit. The biggest problem is we don't really know the bone mineral density. You know, we never know with any of these drugs how well is it predicting whether you're going to get a fracture, which is the real problem. So hopefully you won't. Well, I'm a little reluctant to say that, but what I will tell you is none of the studies that do, none of these studies now do placebo only. They always do placebo plus calcium, and they do the drug plus calcium. So nobody is willing to give someone who's got osteoporosis just placebo. If you actually read the studies, they almost always have calcium supplements. So clearly the bone researchers feel that there's some benefit, because they wouldn't just give you that when you run the risk of kidney stones. And as long as there's any risk, then you have to be sure the benefit is there. So it's just not as good as, you know, it would be better if you did have estrogen, but I don't push estrogen at all, because I think the stroke and the blood clot problems are not ones that you wanted to get into. Yeah, that's probably the other drug company going against it. But you know, the bisphosphonates, we used to worry about that. In fact, there was a treatment before that was really like that, that put on huge bone mineral density, and I'm failing. Do you remember what it was? Fluoride. We went through a phase where people were real excited about fluoride because it really put on bone mineral density, but it was brittle bone. I don't think the bisphosphonates are coming up with data saying it's brittle bone. It is true that we need to keep studying them, because that long list that I showed you, they're all brand new. I mean, we don't have, you know, Fosamax has been around for a while, but we basically don't have a long enough track record to be completely confident. But at least with what we have, that's the recommendation. And for cancer patients, you know, especially breast cancer, where you just, if you have estrogen receptor positive breast cancer, you do not want to take estrogen, so you have to take something. Raloxifene works too, so you could do that. But there's no, I don't think there's evidence that it's brittle bone. I just don't think there's good enough long-term evidence. So, you know, that's, and we won't get it because they'll have something new before we ever get to find that out. That's part of what you have to do in the business. You know, not that I'm aware of. I think the calcium in orange juice is just as good as dairy, but I'm not absolutely sure. And I think that there's chocolate now that has it too, which is now being touted for its antioxidant benefits. So phytoestrogens, like soy is a good source of phytoestrogens. Flaxseed are good sources. You know, to actually get enough estrogen to make any kind of impact, you have to eat a lot. And so it's not, you know, like I think flaxseed, people, Christopher Gardner always tells you need a whole football field of it. You know, the challenge with phytoestrogen for breast cancer, and this is one that, you know, when we were doing the WELL study, which was, they were all early stage breast cancer women, and a lot of them wanted to use soy, is we just don't know, is it acting like a SERM, a selective estrogen receptor modulator, where it's going in and blocking the breast, or is it acting like an estrogen? And so we went through this literature in great detail and pretty much came up with, if you're eating just normal amounts, it's probably not dangerous, but don't go overkill with it. Don't feel like I've got to have soy. It's not something that you have to avoid. You don't have to avoid tofu and things like that, but it's not something that we would say you need to be eating mega doses of it. So it kind of fell in the middle. And the soy literature is really interesting because, at least with the animal literature, they've shown that if you were exposed to soy when you were a pup, like a rat pup, 6 weeks old, and then later exposed to it, you had a very different reaction than if you were not exposed to it as a child. So there's something about, we talk about epigenetics now, there's something about what it did, having been exposed to something early in life will have a different effect. And so some cultures eat a lot of soy from the very beginning, and for us to now start taking it later in life. So it's very confusing for me, but the bottom line is I don't think, I personally don't think it's dangerous, but I wouldn't eat too much of it. I don't, until we really have better data, I wouldn't take my risk. Thank you for that one.
Yeah, thank you.